Hi, good afternoon. It's welcome to another edition of Newton-Wellesley Medical Group Lunch and Learn. A happy Thursday, rainy Thursday today, but we're really excited to have our chief of cardiology to give us a lesson on lipids and to talk about the Newton-Wellesley Hospital Lipid Clinic. We're really happy to have George Philippides here. I wanted to make sure that everyone knows, of course, you can claim CME. And the code today looks like Tokyo mixed up with a P, Toy Cop. And go ahead and, in the typical fashion, go ahead and grab credit for CME today. I also like, as you know, to tease you, to tell you guys what's coming up. Next week, we have a talk on the rotator cuff by Tim Foster. Following week, updates on prostate cancer by our cancer team. And then we're going to sandwich the two shoulder talks with a prostate cancer in the middle. And Jay Simon's going to talk to us about shoulder replacement. So we're excited about the next upcoming talks. There won't be a talk the following week, obviously, because of the holiday. And I'm going to hand it back over to George. I'm going to try to stop sharing and have him share, and we'll see if that works. If not, George, I'll just take the screen back. So go ahead and push share now and put your talk up.
Okay, so far so good.
There you go. You got it.
I think that worked. Okay, let me just. Okay, so I just have to get the right slide. Does this look okay, John? Is this what you guys are seeing?
It looks fine.
Okay.
You're just giving away all the answers. There you go.
Okay.
Okay.
So thanks, John, for inviting me to speak today. And a special thanks also to Audrey for organizing all this, and mostly for putting up for my 5 or 6 last-minute edits and tweaks of the slides. Audrey, you've got a lot of patience, and I really thank you for that. I'm going to spend the next 20 minutes or so talking about the Newton-Wellesley Hospital kind of lipid management clinic, and hopefully have some time to talk about one of the things that we see commonly in our clinic, which is statin intolerance, which is an important issue. I'd like to say, first of all, by way of introduction and to be accurate and humble, that really our entire clinical crew manage lipids really well. I think, to be humble and honest, our clinic is really more of what I call a collaborative clinical funnel, where we funnel specific lipid issues to just a few providers. I'm one of them, but really the key and the special sauce to our clinic is our star clinical pharmacist, Erica Felix Getzik. Unfortunately, Erica could not be part of this today. I'd wanted her to be, but she really works side by side with me and the other clinicians to make sure that the diagnostic and therapeutic plans that we come up with go into play. She does a lot of great teaching on drug interactions. She helps people get the best deal on the drugs that we write for. And she really does a lot of the follow-up before she hands the patients back to you guys. So again, for lipid management in Wellesley, it takes a village with Erica on the top of that hill. So what kind of patients do we see in our lipid management clinic? We see kind of the usual bread and butter patients that you would imagine. So we see all kinds of patients with extremely high cholesterols, isolated high triglyceride levels, and isolated low HDLs. Of late, we've been seeing a lot of patients with vascular disease who are unable to achieve their cholesterol goal for whatever reason. And many of these patients are referred specifically for and ultimately do get initiation with a PCSK9 inhibitor. We have the system down between our nurse, Nathalie Pommier, and Erica. We've got this great system where the paperwork gets done, the PA gets done, the insurance company gets checked, they get to see Erica for the follow-up teaching on the injection. We started a lot of people really successfully on these new medications with some great results. We also see patients without known vascular disease who have kind of intermediate risk for developing vascular disease, who want to come in for further discussion, an in-depth discussion on the pros and cons of either taking the medicines or getting other tests. Dr. Parpos gave last week a great talk on the utility of calcium scoring by cardiac CT to sort of help with this. And these are exactly the kind of middle of the road patients that we see all the time. They're some of my favorite ones because you really get into some great discussions. And ultimately in these patients, it's the discussion and the patient choice that makes the final decision. We're there to sort of oversee the discussion in an extensive way. Finally, we see a lot of patients with quote unquote statin intolerance. And after I do some housekeeping, that's kind of the group of folks I want to sort of focus in on because I think they're interesting and they're a group that we all see kind of all the time. So a little bit of housekeeping. We definitely leverage very heavily lots of the other programs within Newton-Wellesley and without. So for example, it's not at all uncommon for me to see a lipid patient and then have them go over and see Dan Destin or one of his staff of the Shipley Fitness Center, nowadays virtually, to come up with a customized exercise plan for them. We're also in the process, as I think John knows, of coming up with a way that our PCPs and nurse practitioners can actually put in a prescription or a consult for a physical activity consult. And our vision is very, very soon we'll be able to click a button, have somebody from Dan's group get together virtually with our patients and basically say, okay, where do you live? What stuff do you like to do? What orthopedic issues do you have? What clubs or YMCAs are you near? And come up with a customized game plan. And then through fitness trackers, have that staff follow along kind of loosely to make sure those things get done. We think that's sort of a glaring need here, and we're working on ways to offer that to our employees and to our patients in the community, focusing most on older folks. And at some point in the future, John, maybe when it's my turn again, I'd love to come back and talk about that project because I'll need everybody's sort of help on that one. We are also very, very keen on using different diet and nutrition programs. I did want to give a shout out to the fact that Newton-Wellesley Hospital, in conjunction with MGH, just hired 2 fantastic medical obesity specialists. So for a long time, we've had bariatric surgery and we've had dietitians. So we've had left field and right field. But I found in my practice that a lot of patients didn't need just those or needed something more. So now we have folks who are well-trained endocrinologists in this field. And I believe starting in mid-November, John, we'll be able to refer to them. And I think that's going to be a huge, huge boon to our patients and our PCPs. And I'd love to see them sort of get on this noontime series. I see you nodding. And we also do send patients to the lifestyle medicine program. Kim Parks presented that a little while ago, especially the more motivated patients who really want to focus on all the pillars and especially a plant-based diet. So for the very motivated people. Finally, I will say, again, with all humility, we are not at all embarrassed to send patients on directly to the MGH and the Brigham for more advanced lipid management. I have very good working relationships with Linda Hemphill at the General, who's in their lipid clinic, and Jorge Plutsky at Brigham and Women's. In anticipation of this talk, I reached out to them and said, hey, is it okay if I sort of throw your name up here as other kind of more tertiary care options? And they said, yes, thank you. They tend to see folks that we see after we've tried A, B, C, D, E, and F. But there are some folks, for example, that I'll refer on to them directly. For example, if somebody really just has bad vascular disease and we cannot control their lipids and maybe need LDL apheresis, Linda Hemphill oversees that at the General. There are other folks, for example, young women who are in the reproductive years are now planning a family, but have familial hyperlipidemia and need a statin for as much of the time as they can. That's tricky because of the potential teratogenic effects of statins. So there are some folks that I also will work either in conjunction with or send patients to those 2 providers. The only downside, and this is not to say anything bad, is the wait list is a lot longer there. And if there is an in-person visit, it's a little bit more difficult. But again, we work closely with those guys, and so can you. I don't know, John, if you guys have talked about the Brigham and Women's remote cardiovascular health program. I actually think it's a really nice program. If you have somebody and you know that they need a statin, and you want somebody, I think they're usually clinical pharmacists, who will call remotely and go over the plan overseen by the Brigham cardiologist. They'll do the follow-up teaching over the phone. They'll do the follow-up lipid management. And especially during COVID, it's sort of a nice thing to avoid more in-person touches. So that's always an option. And then finally, to finish up in the housekeeping, we love when you guys send us patients in the usual way to see them in person or virtually. But if there's a really simple lipid question or any question at all, we want you guys to remember that we do e-consults. And sometimes I'll get, something, most of the lipid ones end up coming to me. And things like, which statin should you start? This is the presentation. Do you think a calcium score would be good? Those are all fine questions, and we're happy to field things that way, sort of whatever helps. Our style, by the way, is when we do see folks is to begin the game plan, have Erica set up a follow-up plan as far as lipid checks and management, and then have them go back to you guys. We generally do not refer on to other places or to other programs that are mentioned here without getting kind of the okay of the PCP. And so far, it seems like that's about right. So 35,000 foot view, this is sort of how we organize our efforts, and hopefully that's helpful. On the ordering screen, it's a little bit confusing because there are three things that sound similar. Lipid Clinic is what we're talking about here. Really focus only on lipid issues. Click that button. If you want somebody to get a full cardiovascular disease prevention evaluation, say for a profound family history of early disease or worries about lots of risk factors, usually it's this button, the cardiovascular disease prevention button. And as I mentioned, this is the one that Kim Parks talked about, which focuses a lot on a plant-based medicine, plant-based diet. All right, let's now talk about a topic, and the topic for today is statin intolerance. So it sounds odd because we seem to see it all the time, but up until about a couple of years ago, there wasn't even very much agreement in the literature as to what it was. And so in 2017, the ACC finally decided to come up with somewhat of a unified definition for what this entity is. And it's sort of simple, but it needs repeating. Statin intolerance is unacceptable symptoms or biomarker elevations that resolve with stopping or reducing the statin. In order to be deemed statin intolerant, you have to have been intolerant of at least 2 different statins and 1 at minimal dose. This is actually important from the insurance company point of view because oftentimes they won't let you go to option B or C unless this is well documented. Symptom and biomarker changes should not be attributable to other causes. For example, inflammatory diseases like RA or to drug-drug interactions. So you have to do your due diligence. In regards to how often this occurs, what we know is that the vast majority of these events are what's called SAMs, statin-associated muscle symptoms. That's the lion's share of why people stop this. What is still debated, even to this day, is how common this is. So if you speak to somebody who runs randomized trials, they'll tell you, you know, this never happens. It's about 1%, because we know in placebo trials that as many people say they get muscle aches on the placebo as they do from the statin. This is all the nocebo effect. It's the perception on the part of the patient that this is going to do me harm, and then they basically think that that's what's doing them harm. On the other hand, in clinical practice and in observational studies, the rate of dropping out of a statin because of muscle stuff is about 11 to 30%. Now, we live in the world of practice, and we deal with the 11 to 30%. So this is a very common thing. So whether it's a nocebo effect or it's the real thing, and it can be hard to know, this is something that we have to deal with. What is absolutely clear is that the clinical impact of statin intolerance is huge. So one large Medicare review showed that in patients who had suffered an MI, those who could not take a statin and were not on it had a 50% increase in risk for recurrent MI or revascularization. That's huge, okay? So you're taking a high-risk population and taking away about half of their protection by not giving them a statin. So that's why, at least in the cardiology world, when we have a patient with vascular disease, and for whatever reason they're not on a statin, that's an alarm bell that goes off to us. We feel like it's really our job to sort of fix that. I want to make quick mention that the other kind of severe muscle stuff that I'm noting here, very, very infrequent, okay, and almost always reversible, all right? I'll make special mention of new onset diabetes because this is one that we talk about all the time. And the American College of Cardiology has reviewed this, and here's what they say. Yes, using statins will slightly, about 10%, increase your risk of developing new onset diabetes. But the risk is almost exclusively in patients who are getting high-dose statins who already have risk factors for going on to diabetes. So these are people with BMIs over 30, metabolic syndrome, borderline high sugars, that kind of thing, okay? One trial, the Jupiter trial, looked at the diabetes issue, and they found that if you had no risk factors for going on to diabetes and you got a statin, what they found were 0 cases of new onset diabetes, but that you stopped 50 MIs or strokes. And even if you had risk factors for diabetes, in those cases, for every 50 cases of diabetes you caused, you stopped 93 strokes and heart attacks. So even though there is an increase in diabetes, it's overwhelmed by the benefit that you get by stopping those major events. And so the recommendation is, if somebody should be on a statin, put them on a statin. If they have risk factors for diabetes, get them to exercise and to lose weight and all that stuff, okay? So the risk-benefit ratio is in favor of this. I could give another hour talk as to which statins we want to use or how we go about that, but I just wanted to give sort of that overarching review of the diabetes issues. As far as other reasons for starting statins, here's my summary slide. These bullet things come up all the time. But in all honesty, there's very little or no supportive evidence that has been well done to support any kind of major signal here that there's anything more than an association. Okay, so again, if somebody has a good indication for a statin, we do not worry about these things. Folks report them, clinicians report them, but the data is really just not there. All right, so let's get clinical. How do we address or evaluate somebody who's coming in with muscle symptoms who are on statins? And again, this is coming from some ACC and National Lipid Association guidelines. I kind of made an amalgam here. If you are really, really into this, if I really inspire you to become a statin intolerance specialist and you want to go to an amazing app by the ACC, I strongly recommend that you write this down. It's very, very thorough. It's actually so thorough that I don't use it because it takes a long time, but it's really good at certain things and it does all these things nicely. What it's really amazing at is being able to quickly look at your statin and look at drugs, and it rapidly tells you what the interaction is and what to do about it. So for the drug part, it's really great. But I'm going to summarize here. So when you're evaluating somebody for SAMs, the first thing is you want to take a good history about what their muscle symptoms are like. Secondly, you want to look and see, are there endogenous to the patient or exogenous lifestyle risk factors for them to develop SAMs? Are there possible drug interactions? Always have to check the drugs. Third, are there lifestyle factors that might make their muscles more achy than the next person? And then, of course, you check basic labs. So this next slide basically shows a risk score that some group came up with to try to see if somebody probably, possibly, or unlikely has the muscle aches because of the statin. I don't use this risk score. What I do is I look at the general themes from this, and I sort of use it in my thinking. And the bottom line, the things to remember are this. Muscle aches because of statins are generally symmetric in the large muscle groups, most commonly the thighs, and then the calves and the shoulders. Okay, if somebody says I've got just in my forearm on Tuesdays, less likely. If somebody says that I get it after exercise in my thighs, much more. There has to be a temporal relation to starting and stopping. So if you develop the symptoms within 4 weeks of starting, very suspicious. If the symptoms go away within 2 to 4 weeks, very suspicious. And when you re-challenge, if they come back again within 4 weeks, suspicious. And those are the things that we're looking for in the history to try to give us an idea. You know what? This sounds suspicious. Sharp pains, joint pains, fleeting pains, unilateral pains, small muscle groups, much less so. The one thing that I might ask as a mini favor is if when you guys do send us folks for evaluation of statin intolerance, if you can, just let us know what the statins were and when, then at least it's sort of easier to dive in and sort of find out the details about that. But otherwise, don't worry. The detective work is stuff that we do, and it's not a problem. All right. Once you get the history down, the next thing is you want to say, well, is there something about this particular patient that makes them more prone to have this? And that's what I'm showing at this slide. So no question, advanced age, lower BMI, female gender are all risk factors that a certain dose of statin will make you more likely to have aches. Interesting, Asian ethnicity, especially Japanese people, have a much lower threshold for muscle aches because of statins. Any pre-existing neuromuscular, liver, kidney disease, hypothyroidism makes you more prone. Vitamin D deficiency, and finally, a family history of statin intolerance, usually because of some enzymatic issues, are things that you'll ask about. Exogenously, I don't know if that's a word, but exogenously, other things that can enter into it is just being on a high dose statin is worse than low dose. It does seem that the lipophilic statins shown here seem to be more likely to cause the muscle aches than some of the other ones. Probably on the lower end is maybe pravastatin. Excessive drug and alcohol use will also make you more likely. We have a lot of young weekend warriors who go out and, these are usually the weekend warriors who go out in Wellesley and they bike 40 miles and then they're more sore on Monday than they're used to. That'll do it along with dehydration. Grapefruit juice, because it's a CYP3A4 inhibitor, will lead to more buildup of statin and also cause some of these muscle aches. And then finally, as always, there's a myriad of drug interactions. These are kind of the big food groups of the drugs that cause it. So we'll also take a history and look to see if any of these things are going on, and if we can sort of intervene or change these things in order to get somebody back onto the dose of statin that they need. And then these are the basic labs that we check when somebody comes in and they're having muscle complaints. All right. I'd like to now end up, by the way, how am I on time, John? What time are we at?
You're okay. You got another 10 minutes. You leave a few minutes at the end.
Perfect. Okay. So I'd like to now talk about the approach that we take when you guys send somebody in who's not doing well on 1 or 2 statins, on how what we do to try to figure out if it's the real thing, and also what can we do to maybe get them on a good statin dose to protect them. So first of all, when they come in, we do a 35,000 view and say, look, how much do I really want this person on a statin? And for the sake of discussion today, let's say it's somebody that's got known vascular disease, okay? They've got CAD, they've had MI, they've had a stent. This is somebody we really want to put in a statin. So this is not primary prevention with a middle of the road risk. This is somebody we want on a statin for big impact. So first, if their symptoms are mild, the first and easiest thing that we will try to do is just to reduce the statin dose, the one that they're on, and see if we can find that way the maximally tolerated dose, okay? On occasion though, we try that, they don't do well, or the symptoms are just intolerable. And in those cases, it's really best to stop the statin for a minimum of 2 weeks. There are some societies that say 4 to 8 weeks. I've got to say I'm not that patient or something, but usually we go for a minimum of 2, maybe 4. And in the vast majority of people, by that time, you're going to have a signal. The symptoms abated, in which case it's still good, could be because of the statin, or they stayed the same, which is really helpful because you can tell them, look, you stop the medicine, the symptoms are still there. I don't think it's a statin. Let's start it up again at the dose that was sort of evidence-based and see how you're doing, okay? Now, assuming that the symptoms resolve after you stopped it completely, what all of the guidelines recommend is you do a re-challenge. Again, this is a patient we want on a statin. And one thing that the literature says that I find hard to believe, but I've got to repeat it because this is what the guidelines say, is that there's a 90% success rate at 12 months of re-challenging with different statins. And I have to be honest with you, I don't think that my success rate is anywhere near 90%. I don't know if it's because being in a clinical trial, there's different kinds of time course. I suspect it's mostly because I'm so impatient, I'm not willing to do some of this stuff, and I'll show you what I mean in a second. But all kidding aside, in people with vascular disease, it really does behoove the patient to take a long time and make every college effort and efforts, plural, to get them on by this method. So here's what we do. We'll try to re-challenge them in a different dosing schedule with the same statin or oftentimes a different statin, okay? And when we do that, we'll often start with using a long-acting statin a couple times or maybe even once a week. And the reason for that is you want to start low and go slow to confirm, okay, at this dose once a week, nothing happened. Then I gave it to him 2 times a week, nothing happened. The nice thing about this intermittent dosing, and by the way, you're supposed to use the long-acting statins, the one that I showed here. The nice thing about that is if the patient is diligent, and some of our patients are, they'll tell you, I took the statin on Sunday, I started getting my pain on Monday, Tuesday. That's actually a pretty good sign that it was the statin because usually the statin muscle aches spikes when the peak blood level is there, and that's about 1 to 2 days after dose. So by doing it once a week or twice a week, it gives you enough space to sort of figure that out with the patient. And some patients are really clear on that, right? You guys know they'll come in with excruciating detail about sort of when they got it. So it's helpful information to do it that way. Intermittent dosing, it's underappreciated. It can be fairly effective. If you can get people on a decent dose every other day or so, or a few times a week, you can get 20 to 40% reduction of LDL. And in a lot of our patients, that's sort of enough to get a good cardiovascular impact, okay? So we watch them that way. And again, try to increase the frequency as much as we can until we find sort of what that boundary is, okay? Now, another strategy, and this is better for those folks who can't tell you the exact day, they can give you roughly, I took it for 4 weeks, 3 months, and then somewhere around June, I forget, it was my daughter's wedding, I started getting the aches. So in those folks where it's much more gradual, another way to do it is to basically give them a 3-to-1 ratio, 3 months on, 1 month off. What you're supposed to do is take the period that they tolerated it, divide that in quarter, and make that 1 quarter be the time off. So I have an occasional patient who'll be on something for 3 weeks, off for 1. It's not as good as continuous, but you get a lot of benefit from that. So I don't want to get too deep into the weeds, but this is generally the kind of thing that we try to do. And again, this is where Erica is so fantastic because she will do the follow-up, check in, change the frequency, check the CKs and or the lipids again until we're sort of at a plateau. at which point we can hand them back to the clinicians with hopefully some good amount of LDL lowering going on. So again, this is broad strokes, the general strategy. I want to mention, and this is important, that the ACC mentions this, that intolerance to one or more statins does not necessarily indicate intolerance to all. The statins, I could show you a slide, have lots of different features as far as duration, lipophilicity, drug interactions, enzyme interactions. And so sometimes when you do try 2 or 3 different statins, you will come across one that works. With 1 minute left, because I want to keep some time for questions, I did want to mention that there are some medications that you can try for people who are absolutely statin intolerant, who just can't take any of it. But I will mention that the FDA has not been willing to approve any of them. And the reason for that is they're afraid that if they approved non-statins for quote unquote statin intolerance, that people would not go through the machinations that I showed you on the slide before, and they would jump directly to these medications, which just don't have the data for huge impact. And so for that reason, these really are only kind of adjunctive or secondary to true statin failure, as I showed on the slide before. With that said, is generally the order that is considered appropriate and evidence-based is to go to ezetimibe, Zetia next. The reason for that is there is one trial, the Improve It trial, that showed if you added Zetia on top of maximal statin in patients with vascular disease, that you get another 10 to 15% LDL reduction, and that translated into a reduction in cardiovascular events. So there's data for adding Zetia when you've maxed out on the statin and aren't at goal. What's nice about Zetia, it's another one of these longer acting ones. You can use 5 milligrams a day if you're really worried about intolerance, and you can use it every other day, and you get about a 15 to 20% reduction. So it's a fairly good thing to use. Bempendoic acid, I just mentioned it because it's new on the Newton-Wellesley Hospital and Partners formulary. It's got the same indications. Folks with really high cholesterols and vascular disease who can't get there on statin, but they have a weird caveat that it's got to be written only by people with experience with it or cardiologists. So again, for the near future, this one will come probably through us. And then the other one that you guys all know about are PCSK9 inhibitors, which you've been referring in for appropriately, and we've been starting. I'm not going to go through the rest of this slide, but I wanted to jump down to the last 2 bullets to talk about vitamin D and coenzyme Q, because this comes up a lot. So I wanted to say a couple words about that. And I'm happy to field questions on the other stuff too. Here are the facts on vitamin D. Patients who are vitamin D insufficient have more muscle aches than folks who don't. That's true. Repleting vitamin D in many patients, not all, makes the muscle symptoms better. Patients who are on a statin and also are vitamin D deficient have more muscle aches than patients on a statin who have normal vitamin D levels. But what we don't know is the last part. Repleting vitamin D in statin patients, does it make a difference? Some studies say yes, and some studies don't know or say no. So the way the ACC comes down and the way that I do, because again, I'm not a trialist, I'm a clinician, is I replete it. I warn folks that it will take at least a couple months to see the full effects of that, and it's good for you anyway. It might even ward off COVID, I'm hearing from some things in the news. So we do it with not great evidence supporting it because it's a good thing to do. Coenzyme Q10, same thing. We know that statins deplete that coenzyme, which you need for mitochondrial energy creation. We know that folks, when they have that repleted, their levels go up. And some folks, they'll notice improvement, but there are no clinical trials supporting it one way or the other. Again, it's totally benign. I think there is a little bit of placebo effect because I've seen it with my patients. They swear up and down they feel better. They know the dose. And since there's nothing wrong with it, I go ahead and do it. So, but that's the data or lack thereof on those two. So with that, I'd like to thank you guys for your attention, and I'd be happy to take some easy questions.
George, thanks for such a fantastic talk, really clear, and we'll get this up on YouTube so people grab the slides. A couple of quick questions, maybe you can give a quick answer. If people want to stay on, they can. If not, there was a question here, which any preference for lipophilic statins with statin intolerance? I mean, is there one that you reach for when I send you the patient that says they can't take any statins?
Yeah, I like rosuvastatin for 2 reasons. It's pretty potent. It's lipophilic and it's got a longer half-life, so it's one of those ones that lends itself really well to once-a-week dosing.
Okay.
If they had the problem on that, the other one that seems to have, we think, slightly less muscle stuff is pravastatin for probably the same reasons. It's shorter acting, but I still think you can use it that way. So those tend to be the two that I toggle between when somebody has failed one of the other statins. I will say, here's a bias. I never use simvastatin. I just don't see the reason. It's not as potent as atorva and rosuva, and it's got way more of these enzymatic and drug interactions. If somebody's on it and doing well with it, obviously I don't shake the boat, but I don't see the need for that one. The other statins all have their little idiosyncrasies and things that are good about them. For example, pitavastatin, which you don't use very much and can be expensive on some insurance companies, seems to have the less effect on glucose. But as far as simply the lipid and the muscle stuff, if I had to switch over to answer your question, John, it's rosuvastatin.
There's another question, two quick ones really. One is about the Zetia alone and any improvement of CV outcomes. And then the last one I'll leave for you. It says, is there a better time of day for folks to take the statins in general and maybe in reference to the muscle aches? And then we'll end the talk after those two questions.
Yeah, so the data that I know in Zetia is in combination with maximally tolerated statin in the IMPROVE-IT trial. So by itself, I don't know that I can point to a study that shows benefit, but every other study shows that the LDL to CV risk curve is continuous. So even off statin, if you take Zetia and go from a LDL of 100 to 80, which is reasonable, you should be getting that benefit. I just am not smart enough to be able to show you that clinical study. More data in combination with, but I do it even without because it's the next best thing. Now, of course, if we have somebody who's not starting at 100, they failed and they're at 200 LDL, that's a different story. That's when you're going for the PCSK9 inhibitor. So that's kind of how I use those. If I'm close, I'm reaching for Zetia. It's less costly. It's a pill. And if they have really high ones or really high vascular risk, then I'll consider the PCSK9. Those two I toggle in that way. And then as far as time to take it, there seems to be a little bit better metabolism at night. So there's slightly more efficacy at night in regards to LDL lowering. But I don't know if there's any effect on muscle symptoms. I don't know that.
George, thanks again. Really terrific talk. Folks, if you want to really get your patients to get the expertise we just heard for the last 30 minutes, definitely refer to the Lipid Clinic itself. I have myself, and it's really awesome. Thanks again, and everyone have a great day and a great weekend and a happy Halloween, and we'll see you all next week to hear about the rotator cuff. Thanks again. Bye.
Thank you, guys.